Hello and welcome. My name is Justin Davis. I'm an interventional cardiologist from the Hammersmith Hospital, which is part of Imperial College. It's my pleasure to welcome you to this interventional cardiology review in association with Radcliffe Cardiology. Today we have the pleasure of having Corrado Tamburino, who's a professor of intervention at Catania University in Italy.
Yes.
And also, of course, a world authority in intravascular imaging with IVUS.
Yeah, very gentle. I'm not a world authority. I'm an interventionalist, so that I'm a user. So, using this technology, I acquired some experience.
So how important is IVUS use for you?
IVUS is very, very important. At least in the last years, we acquired a lot of information confirming the utility of this tool during coronary interventions. And particularly in the last years, we understood that the use of IVUS is even more important in BVS era, where we don't see the scaffold, so we need to have further information and supplementary information for achieving a good result. And despite that, we know that in Europe, the use of IVUS is restricted to 5% of the whole number of procedures. This is related to several factors that we can discuss if you want.
Yeah. So that's a very interesting question. So you say there's a real need for IVUS imaging, but yet only 5% of the doctors in Europe are actually using IVUS regularly. Why do you think that is?
I think that there are several reasons. Mainly, interventionists are animals. They do the same job, and the same way for years, and changing the habits is very complex in a setting such as the cath lab. So you do the PCI always in the same way to change it. First. Second, the cost. We know that when you do, the more you do, the more you spend immediately. Although you save in the general cost analysis in the global health service, but in your hospital, if you do an IVUS, you spend more money and more time. And third, I think there is a psychological factor which is important, because when you treat a coronary patient, regardless the stent deployment is correct or not, you get an immediate success. So you don't care what happens 1 month, 6 months, 1 year later. So you can stop the procedure saying, okay, it's good, and you will never know if the patient will do good or not in the follow-up. So these three reasons combined make the use of IVUS lower than it should be.
So that's a very interesting point. So in your final point there is you're saying that we finish the case often, we've got an angiographically nice result, and you say, great. But really what we should be thinking about is how that patient's going to be doing in 1, 2, 5 years' time. And that's really where the IVUS may be making a much bigger difference.
Yeah, and also there are some studies. I can tell you about the ADAPT-DS, which is a study that analyzed the use and the resistance to antiplatelet therapy. But there was a subgroup of 40% among 8,000 roughly patients that used the IVUS. In those patients, 74% of these cases, the interventionist changed the way to implant the stent, changed the direction. So post-dilatation, one further stent, or correction of the overlap, or extension of the length of the stent. So it is important, because with the angiography is an archaic system for coronary angiography, for coronary intervention. We use it because it's the best way, it's the simplest tool, is reliable because you see the anatomy of the coronary arteries, but for stenting is archaic because we don't see inside the artery, and we don't understand if the stent is well implanted, badly implanted, is the lesion is full covered or other.
Yeah. Well, I mean, personally, I agree with you. I'm always surprised whenever I use IVUS that you often see a very different image from the IVUS catheter that you do from the angiogram. Yeah. So that really leads me on to, where should we be with our IVUS usage? We see people like Dr. Park in Korea, S.J. Park,
Yeah.
who has mandated IVUS use as his institution for almost 100% of people.
Yeah.
Do you think that's realistic, or do you think we need 100%?
So I don't think we need 100%, but a high percentage yes. Dr. Park, S.J. Park, in his experience, has reduced dramatically the number of stent implanted and the lesion treated by IVUS, and combining with FFR in some cases. So he did an integrated analysis, a morpho-functional analysis, and so he understood and he discovered that many lesions that we treat shouldn't be treated. First. Second, the more IVUS you do, the more you save in terms of long-term results and then of costs, because you know that when you have a malapose stent, you run the risk of a scaffold or stent thrombosis, and so you have to keep the patient for long-term and during implantation therapy. You do angioplasties, you have suboptimal results that are determinant for stenosis, especially in bifurcations or in small vessels, and sometimes you don't understand which is the true caliber of the artery. So I'm impressed in many cases where I implant a stent and I think that the stent is well implanted and I want to check with the IVUS that in almost all cases I'm not right. I have to post-dilate, I have to change something in the procedure. It's impressive. I do 20-30% of IVUS, but I think that we should do more.
Yeah. So even with your lifetime's experience of doing a lot of angiography, many stent implantations, you're finding very, very frequently your clinical decisions are changed.
Yeah, this is, I would say, I use IVUS when I have some concern. So there is a bias. So when I have no concern, I don't use IVUS, but I don't know if the implantation is correct. But when I think, oh, I want to do IVUS, always something wrong. There is something wrong, always, almost always. And it is true.
That's very interesting. And so it's essentially you're taking a few more moments at some part of the case to benefit the patient long term.
Yeah, absolutely. And when you have a well-apposed stent, you can stop the dural implantation therapy even 1 month later. This is something that many of the stents are indicating 1 month or 3 months adapt. But if you are sure that the stent is well-apposed, it is much better. It's much better.
So, this really leads very nicely on to some things which are changing in our field with regards to stents. And we've seen, of course, go from bare metal to different variations of the drug-eluting stent, and now there are various offerings of the BVS scaffold.
Yeah. BVS, I have a particularly huge experience with BVS. I've implanted 100 and 100 and 100. And I started since the beginning doing IVUS and OCT as well in those patients. I think that with the scaffold we have to pay a lot of attention, a lot of care in assessing exactly the anatomy of the artery we're going to implant a scaffold, because we know that we have a limit of expansion of the scaffolds, as well as we have we don't see the scaffold, so we don't have visual information. And so we understood that, and also the type of lesion, we have to prepare the lesion. So assessing the lesion, preparing the lesion, implanting, post-dilating, and assessing the final result are steps that require in different moments the use of intravascular.
So can you just walk us through? The patient comes in, you turn an angiogram, you think they're a suitable candidate for a BVS stent. How would you go about implanting that? What steps would you take?
The step I do is first is the assessment of the caliber of the artery, and I do the pre-dilatation with a balloon that I think is the same of the artery. The ratio is 1 to 1 to 1, so I stretch a little bit the artery in order to see if there is any waste on the balloon. If there is no waste in two orthogonal views, I go for the scaffold implantation. This happens in the majority of cases, I would say 70% of cases. In other cases, we have a recoil, resistance, we have long lesion, we don't know if there is a lot of calcium inside that we don't see by angiography. We need to use cutting balloon or scoring balloon or rotablator. In those cases, always I use the IVUS or the OCT because I want to assess the exactly the dimension of the artery, the structure of the artery, and this IVUS is better than OCT because it gives you a comprehensive analysis of the anatomy and the media to media distance, which is very important, is well detected, especially in large vessels. I mean 3.5, 4, where the scaffold is mostly applied and used.
That's true. I mean, I certainly struggled, I think, using IVUS as OCT. Sorry, as the vessel starts to get very big, classification is not so good. Yeah.
Yes, the OCT is useful for endothelialization.
Yeah.
And also because you see very well the struts and of the scaffold better than with the IVUS. But you don't need to see the struts. You need to assess the anatomy of the artery, the composition of the wall, and also once you know the artery, you implant the proper size scaffold.
So if I'm at a centre which is just starting to put BVS in and I have a choice between OCT and IVUS, IVUS is the
you should use both. I would say both. So when you use a BVS, you have is a mission.
Yeah.
Is a mission. You get good results. My experience, we are published with my co-workers the 1 year ghost results in my center with 98% of follow-up in true real-world lesions, so very complex lesions, CTOs, bifurcations, long lesions, and we achieved excellent results with below 10% of a MACE at 1 year in very complex lesions, and we did a lot of intravascular imaging for achieving these results. So if you want to achieve a good result, you have to spend more at the beginning, especially with the BVS.
So it's all about how you make your assessment, how you plan, how you predilate to make sure that you have a good result long term.
Yeah, I predilate with non-compliant balloon if possible, especially in resistant lesions. I oversize the balloon as regarding the as compared with the arterial caliber. Then at this point I implant and I overstretch the scaffold very gently, but I go up with the delivery balloon to 20, even 20 atmospheres. The average is 16. And then I post-dilate in case of need with a non-compliant balloon. So I spend much more time and much more devices. And I use, in 30% of cases, intravascular imaging.
So your time is an investment for the patient's future, really?
Yes, it's an investment because, it's a paradigm shift. You have to change your mind. You want to treat in a more physiological way the patient. So not leaving anything after 3 years. You have to spend much more time at the beginning and more devices.
So in my opinion, slightly worryingly, you see occasionally some people implanting BVS stents without using any imaging modality.
This is a mistake, because at least at the beginning you have to understand how this technology, novel technology, behaves, because it's different from metallic stent. It's thicker, the current generation, so it's more prone to scaffold thrombosis. So you have to know how the scaffold behaves, and to know how scaffold behaves, you have to use the intravascular imaging.
Yeah. Okay. Well, that's very, very helpful. So finally, I was going to just ask you about interesting cases that you've got. You know, a case or two which has really changed the way you do things using IVUS imaging.
I would say that I have in mind a case where that I did 7 months ago, was a relatively young, 58 years old architect with such aggressive diabetes, insulin dependent. And so I did a coronary angiography, and the arterial bed was fully involved since the beginning to the tip. So no chance for the surgery, because in those cases would be, really helpful with a good peripheral bed. So I spoke to the patient and said, okay, I will start to reconstruct your artery in different steps, because I think that is the only choice we have. And so I started doing in right coronary artery as well as on LAD aggressive very aggressive predilatation with cutting balloon in all the whole arteries. Cutting balloon, dissecting, trying to widen the arteries. Then I did IVUS and OCT, both, and then I chose the caliber of the BVS, and I implanted the BVS in right coronary artery and in left coronary domain, in the LDA. In right coronary artery, I did a full plastic jacket, but at the end there was a distal dissection, and I assessed by IVUS. I checked the dissection, was intermediate risk of progression, threatening the artery, and I implanted a metal stent because I had to cross all the previously implanted scaffold, and I wanted to be sure to have a lowest profile possible. And so I reconstructed successfully the right coronary artery. On the LAD, I did the same, and at a certain point I had an intravascular hematoma. So I was concerned because I was dilated after the cutting. I didn't understand what to do. There was the stent, the BVS, 3 BVS implanted already. So I went with intravascular imaging, and I understood that the scaffold at that point was completely distorted and deformed and destroyed. So it was very helpful because I implanted a metal stent inside the scaffold, so achieving an excellent result. And the patient is doing well at now 6 or 7 months, and we did an angiography at 6 months because I wanted to complete the circumflex artery, and the right was very good, and the left was some narrowing, and I dilated with a POBA, drug-eluting balloon. But in this case, the IVUS and the OCT combined were mandatory and were the reason for the success in this patient.
So even in a well-planned case, clearly a very complex case, things don't always go to plan. And here,
you change your mind.
The IVUS imaging here really helped to.
Yeah, and I think that IVUS is really helpful in bifurcations. In left main, always performing. At the beginning, because when you have intermediate lesions, you have to assess and understand if to treat or not treat. And after, in order to understand if the stent is fully expanded, if you get a luminal area large enough to guarantee to the patient a long-term follow-up, a good outcome, and also for the bifurcation. Could be useful also the FFR for the side branches, and we use in some cases. But I think that in bifurcations and complex lesions, you have to use, because otherwise you run the risk of spending a lot of time to do a complex procedure for nothing.
Well, Corrado, I'd like to thank you very much for your time today, and I think you've addressed these questions, in a very elegant way. We've certainly learned that IVUS is a very, very important tool, which is probably underused still in the cath lab, and perhaps now with an aging population, we have more complex disease. We've got new stents coming into the market, new scaffolds coming into the market, which really using IVUS is a mandatory component of implantation of these stents, and it's going to be very important as these take market share going forward. I'd like to thank you very much for tuning into this interventional cardiology review, and we look forward to reviewing further cases with you in the future.
Thanks very
much.
Thank you so much. Thank you so much. Bye.